Deepak, I do want to publicly say a big thank you, and how I wish you and your colleagues every Godspeed with this project, because I think it's very much needed.
Thank you.
So I'm delighted to be here and in this lovely city. I wish I was going to see a little more of it, but there we are, I'll have to come again. So I just want to tell you that at the European Brain Council, we decided to do a survey of the cost of brain disorders across Europe, and we presented it in the European Parliament in 2011, and I have to say it was absolutely packed. So this is the result of a survey across Europe 2010, and you can see just short of 800 billion euros being spent. Now, it takes a lot to imagine that amount of money, but that is more than is spent on cancer, plus diabetes, plus cardiovascular. It's an enormous amount of money. And there were already beginning to be murmurings of the unsustainability of this sort of thing across Europe. But what is really interesting to see how that money is spent. Of course you would expect it to be spent in the hospitals, and of course in social care with social workers, the district nurses, etc. But look at the highest cost of all. It's on our society. Our world is living longer, and we should celebrate that. In my city, London, 100 years ago, the expectation of life for a man was just 42 years. It's now 78, and for the women, well into their 80s. And this little girl, born in Japan, she's got a 50-50 chance of living to be 100 years of age. It is the most incredible achievement, and we've a lot to thank our public health doctors, the industry, and the clinicians for that big achievement. In fact, Peter Pedersen, who's has sort of worked out in Copenhagen, that probably of all of mankind who has ever been on planet Earth since day one and got to the age of 65, 2/3 of them are on the planet now. Now, so often when man makes a big achievement, it draws along in its wake challenges. Challenge 1. The longer we live, there will be more brain diseases. And challenge 2, the longer we live, we acquire more illnesses. They say once you're over 65, 3 or 4 illnesses are moving on you. Now, I can see some nice young people in the audience, so you want to make the most of it, you youngsters. And remember that good health is just an incomplete diagnosis. So this brings big challenges. Now there's something else going on as well, and that's the changing role of women. Women have always been perceived as the carers of the family. The man does the work, the woman makes the nest and cares. And it's been going on like that for centuries. But again, 100 years ago, there were terrible wars across Europe, and millions of men were killed. And there were not enough men to go around for the women to marry. So after the 1418 war, in family structure, there were many unmarried women, aunts, cousins, living within the family structure. And if somebody was taken ill, they cared for them. Today, it's quite different in Europe. We've got a falling birth rate right across Europe. And we've got, and you can see here in the audience, wonderful career opportunities for women, and let's celebrate that. But it has made a difference, and you can see from these statistics that in the 1920s, a couple in their 80s had 44 female relatives alive, and 14 of them not working outside of the home. You can sort of play this game with your own family and just see the numbers. 2000, we've nothing after 2000, I'm afraid, a couple in the mid-70s had 13 female relatives alive and only 3 of them not working outside. Now this, I thank Panos Kanavos at the London School of Economics. There is an economic ratio that it takes 6 working, tax-paying people to sustain 1 person receiving pension. And you'll see the ratio across Europe. We're well short. another big difference to our society. And of course, as I alluded to, if you've got 3 or 4 diseases, that means it's polypharmacy. And comorbidity, I would say now, is the illness of Europe. Now, this is significant because the organ managing your comorbidity is the brain. And once the brain is compromised, then there are a lot of difficulties. And Norman Sartorius has done a really nice study on this with people living with diabetes. They manage perfectly well until the brain is compromised, perhaps with depression. Hospital appointments are missed. Medications are muddled up. And then the secondary symptoms of diabetes begin. Loss of limbs, loss of sight. Distress mounts for the patient and indeed the families. And of course the cost to the health system goes up. So this is really important. The challenge of migration, that people moving into your countries, there are problems on the hospital systems, quite understandably. Language is different, expectations are different, and they have to accept what is on offer. And we've just done a sort of quick and dirty study of our NHS, and there's a real wastage, a lack of service to these people, and also a wastage of money because things have been misunderstood, language misinterpreted, and just cultural differences. Time with our doctors, 12 minutes. 12 minutes, and it's not you're just seeing a patient with one illness, no. An aging population, comorbidity. Time is precious, and yet we're down to 12 minutes. Access to medication, well, that's very variable across Europe. Some countries have got all the medicines and reimbursement. Others have got the medicines but not reimbursement. And some countries in Europe have got very little. It's an uneven playing field. And frankly, I don't think we're doing nearly enough about the counterfeit medicines. We make assumptions that it's people who are suffering or feeling stigmatized that are away on these computers ordering up their medicines. But I'll tell you, we did a quick and, as I say, quick and dirty piece of research. We got one of the secretaries to use her Visa card and to order up 90 medicines off the internet. All the medicines she ordered required prescriptions. Not once was she asked. And then they arrived, and we took them to the MHRA, where they were unpacked and analysed by the chemist. 61 of the 90 were counterfeit. So it is a really big problem, and I don't think we're doing enough about that. I do know that the European Medicines Agency have it on their radar, but I think we should all be doing more about this. So there's the setting for Europe. Challenging. Way forward. Wonderful words, these. Partnership. Partnership. Real partnership. Trust. Good partnership is built on trust. Richard Bergstrom's really worked hard at FPIA to get on to transparency. And of course, transparency is the first steps towards trust. Innovation. We know we're not bad at that. You scientists are very good at it. Communication. Oh, I think we're not good at that. And that's why I really welcome particularly today, because I'm not sure that society as a general understands exactly what's going on at the moment. So let's look what is on offer in the European Commission. Well, they've got the 2020 programme for a healthier EU, and I think it's doing very well, and I commend the Commission on that. We've pushed for funding, and I really do mean this. We're not pushing cancer out of the way or anything like that. I can't bear that sort of thing. But the brain is really necessary to trying to manage comorbidity. And as I say, the evidence is there. So the brain, we wanted to see more research money and getting some good funding. And the Commission have been very good to us. But one of the finest initiatives, I think I'm always so proud about this, is the IMI, the biggest public-private partnership, I think, on the globe. And it does extremely well. And I loved my time. I was the lay representative on the scientific community, and I learned so much. And Michelle Goldman, who I served then, was wonderful at giving me time to make comments. Here you can see the portfolio and the budget breakdown. And of course, we all know that the antibiotics for infectious diseases are very, very high on their agenda, but they do a wonderful job. And you can see from the work that they've done, their citations too are running at a very high standard. And then we have, excuse me, the JPND research to help the neurodegenerative diseases, and that too is doing extremely well. Really good initiatives from the Commission. But what about society? What are we doing? Where is the word prevention on our radar? I'm going to show you a slide which I'm very, very ashamed of. Here's from the UK. It's an ageing population. We're infertile. We've got the worst sexual health in Europe because we've got so many teenage pregnancies. We're still smoking, still taking drugs, and now we've added to. Alcohol has emerged and obesity. And that's 60% of the budget for the healthcare gone. Not a brain on the table, not a liver, not a heart, nothing there. So this is a real challenge. What are we doing in society? What is the education system doing? What are our schools doing? Why are they so separate with the budgeting? We always know that when our ministers have to go to the Treasury to make their case, some of the tightest competition is between health and education. Isn't there a good case to try to get them a little more together? Because how you learn in school about your body and your lifestyle is really important. And I don't think any of us are doing enough about that. And parental guidance, that too. These are standards that are put down very early in your life and are going to have a big influence on you as your pathway of life develops. I love this quote. He didn't just do the electric light bulbs. The doctor of the future will give no medicine, but will interest his patients in the care of the human frame, in diet, and in the cause and prevention of disease. We really have to stop and think about this and support the Commissioner from DG Sante, who is saying prevention, prevention, prevention. We have to do something about prevention. And I'm not addressing that it's all just vaccination and total prevention of illness. I'm talking about what we can do about the unpreventables, certainly in my world of neurology or Parkinson's, early diagnosis, better management. Some of these neurological illnesses early on are livable with. It's what they deteriorate into with poor management and poor support that causes so much distress. The work at the European Medicines Agency, they really do a very good job there, but their big challenge is safety versus innovation. How much does the society understand about this? And I think when they did do a survey, they were amazed at how much risk patients were prepared to take with medicines. And I always quote here, my dear friend Albert Jovel, who doctor living with metastatic cancer, who's now sadly died, but he always used to say, I'm already in an unsafe world. A little more unsafeness doesn't worry me. Again, the communication between the regulators and the patients is so important. And I have to say, EMA are doing a good job trying to engage them. So we have the regulator and the payer, two challenging people. And of course, they're measuring different things. The regulator is managing the safety of the medicine, and is it better than other medicines in the field? The payer is looking for a societal difference, as something that has made the use of this medicine have a societal benefit. Has it perhaps enabled a patient to get back to work, stop taking benefits, paying taxes? Or perhaps less, is it enabling the patient to be left with some care coming into the home and the main caregiver getting back to work, paying the taxes, not taking benefit? These are the sorts of things that we're all sort of trying to look at. Are the clinical trials really appropriate and useful to a comorbid, aging population? Well, these are the facts. 30% of the clinical trials failed to recruit anybody. 85% of the clinical trials faced delays due to limited participation. Fewer than 10% of the Parkinson's patients ever take part in trials despite overwhelming interest in working with the scientists to help speed treatment breakthroughs. It was when I was the chief executive of Parkinson's UK, it was the constant, every AGM, always the questions. How do we get into the trials, Mary? What can we do? It's difficult. And so I listened to Sir Michael Rawlins, who's head of our MHRA, talking about the variability now of the trials. They're really beginning now to adapt to this ageing, comorbid population, because it's giving big challenges. What are we doing about the patient-reported outcome measurements? You know, Europe is so rich in her science. She's so rich in innovation. But we really have to take to the end of the line the societal impact and what it means to the patient. The patient-reported outcomes are crucial. When I was at EMA, I watched some of the medicines come to market or try to come up to the regulators for Parkinson's disease. And do you know what they measure? Arm swing, improvement of arm swing and stride. You'd meet people with Parkinson's. I don't think that's very high on their priorities. But I'll tell you what is high on their priorities. Living with the illness of depression, sleep problems, fatigue, pain, bowels, bladders, sexual dysfunction. Never thought of. And this is some really good work that we're trying to do now at Oxford University, where we're trying to get a measurement. And we're trying to follow the guidelines for in our country of NICE, who are saying it cannot just be for one illness. It must be a measurement that is generic. The end point, not the doctor's end points, the patient's end point. Reported outcomes which must be measured. E-health and the emerging technologies, and I know you've got Terj going to speak shortly, and I do congratulate DG Connect because you're doing such a great job. And certainly Latvia gave a great impetus with the e-health and emerging technologies. These are going to be really vital. At the moment, of course, we hear about the home monitoring systems, lots of things like this. I don't think really the real impact of this is as far-reaching as we would like it to be. Some people are quite resistant to this, but I certainly don't think, for me as an old dear, my children and my grandchildren, this is going to be such a massive way forward, which is going to start to alter the whole idea and concept of managing your health. The future of medicine, well, today, as you know, we diagnose and treat based on symptoms and a subjective interpretation of symptoms. But look at the future. Diagnose and treat based on biology, select medication based on an objective evaluation of benefit risk for the individual patient. It's all about precision medicine or personalised medicine. And again, I congratulate Luxembourg. They did under their presidency, they really pushed this. But we've so much work to do with the general public, with society. They don't understand about something being personalised, that will predict, that might be prevented, but must be participatory. Look at the prevention in that scheme that is possible. But what does the public, what does society hear? Really only reports about Angelina Jolie, who has had a double mastectomy, a double oophorectomy, and the conclusion to this is that this is probably for the wealthy and the famous. We must improve the communication. It is so very necessary because society needs to understand this new science and new innovation. And then we come to big data. Now, this is really interesting for me because I get asked at a number of meetings. So the first meeting was all about with the pharmaceutical industry, and they're my great friends, so no criticism here. But I was amazed how they thought how easy it would be to capture that information. They thought it only made sense, so surely the society would jump at this. But if you do go, I know we heard a most wonderful presentation just before lunch but that's a very informed patient. A lot of the patients are really nervous about this. Let me give you a group, Huntington's. If there's any thought that their data would get out, that they may well be in the future going to get this illness, who would insure them? They're the questions that are uppermost in their minds. And I don't know if any of you have seen the video where I think it was Roche who went with some of the patient groups to meet with Obama in the White House, where he asked to be really informed about data. What does this mean, the big data? And he says very clearly into the camera, goodness me, that's my data. I own it. Who on earth thinks they own my data? You know, there really is a nervousness here. And I think it's absolutely great that you're having this initiative here, because for me as a sociologist, this is one of the greatest opportunities we could possibly have for health. We're going to collect so much data, and it's real world data, not the PSURs you have been relying on to get feedback as how the medicines are doing. This is the real stuff. People who sometimes miss the odd dose and double up and sort of imagine how they're going to take it, we know all that goes on, and you will get this back. This is going to be the most great epidemiological sort of idea that you could get across Europe. And it's already encouraging, because I know, because I work with the Human Brain Project, that the data coming in from my country, from our NHS, is pouring in. It's well coded, you can't track back who it is, you just know it's female or male or whatever. And already in there making the platforms emerge, there's already parts of Europe that are aging well and other parts that are not. And that's really useful data. So this is, Deepak, I really congratulate you and your colleagues, because this is very important. The patient's journey, they have a very challenging journey. They need a clinician to understand about the disease. They need to be able to talk to industry, and they're kept certainly at arm's length. They're not discussing medication, but they would like to know more about medication. And of course, the groups give them their fellow travellers, which is really important. Imagine if you were on a big journey to a country you didn't know very well. It isn't just about getting your air tickets and your passport. It's always good to talk to people who've been there before. And the patients will tell you, wherever you are, whatever the disease, that when they first receive a diagnosis, whoever you are, whatever your background is they can remember everything about it. They can even remember the pattern of the carpet as they take that diagnosis on board. And the thing that they really overwhelmingly feel is loss of control of their life. That's what we all like to control life. But if you do say to a patient, what are you doing for Christmas? They'll probably reply, I don't know yet, Mary. See how I feel. See where things are leading me. What are you doing for your summer holidays? The same reply. So we have to get back that control to those patients with good, clear information. And again, the whole idea of what is going on here is going to really add to that, to help them to get that control back on their lives. That's what's so nice when I talk to people like you, because the patients have to walk the walk. They've got the diagnosis, they're on the road. But this room is full of talent that's chosen to walk the walk with them. And that's what gives them hope, and that's what is really encouraging to these patients. And it is a challenge to engage with the patients. Not all of them are ready to come forward. Most, and where they are, of course, they do such a good job. But there's no doubt that an informed patient, as Derek Wanless said, is a very cost-effective patient. I have some concerns about this. I want to see that the science that is so magnificent and speeding down the track on that like a motorway, I want to see it underpinned with ethics and social studies and humanities, because I think that's really important. Science is always the how, humanities need the why, and we do need to keep them very knit together. But this to me is the biggest challenge of all. How long does it take to get a new medicine now, from the bench to the bedside? 8 years in development, 2 years going through EMA, Another 2 years in health technology assessment. Most of the ologists, whether they're neurologists or oncologists, will say, well, let's give it another year. Let's just get a little more data. 13.5 years. Wonderful for the future, not so great for the patients who have problems now. My hero. This is accredited to him, or attributed to him. You're not sure if he really said it. It's not the strongest of the species that survives, nor the most intelligent that survives. It's the one that's the most adaptable to change. Today's meeting is about change. That's why it's exciting. And again, the management of long-term chronic illness, because that's what we've got, the comorbidity of Europe, is to adapt and to self-manage, to be able to participate in social activity despite all the limitations, because man is a very social animal. And we have got President Juncker's a European semester to work on, which is the good guidelines, excellent science, innovation, societal impact, but it must be measured. Health is wealth. A healthy nation is a wealthy nation. Let's talk a little less about cost and a lot more about investment. Thank you very much.